it would be good to get started. So thank you to all our sponsors who've helped us make sure that this week happens. And we can move on from there. So the webinar will be recorded and uploaded to our website within about 24 hours, but you will get an email telling you that it's there. The chat's open, so please do say hello and let us know who's in the room, because it's really nice for us to know who we're talking with. The Q&A is there, so we ask that you put any questions that you have in the Q&A. We did, as you know, when you registered for the event, ask for questions to be submitted in advance. So we do have quite a lot of questions, but we'll do our best if we get through the questions already in. Closed captions are on, and we can move on from this slide now, and I think get started. Sorry, the slides are a little bit slow at the moment, moving forward. And I just wait for the slides to go down. Okay, well, I think as we're waiting for this to happen, I'm just going to do ask our panelists to do a very quick introduction, and then we're going to fly back around to say hello and to have the actual conversation. So first on my list is Ruhel. Ruhel, would you like to introduce yourself?
Yeah, thank you, Rachel. Good afternoon, everyone. So I'm Ruhel Ahmed. I'm a patient advocate with over 28 years of experience in the community development. And my work focuses on improving health access and making sure that digital innovation works for everyone, not just the digitally competent. Thank you.
Oh, it's all working. Yeah, slide. Thank you, Ruhel. And then Tara.
Thanks, Rachel. Yes, I'm Tara Donnelly. I've spent 35 years in the NHS in a range of roles, mostly leadership roles in hospitals. I was a director of ops and a chief exec. And then my last job in the NHS was I was the chief digital officer for NHS England, including during the pandemic, which was a really interesting time. But for the past 2 years, I've been working independently with my own company called Digital Care.
Brilliant. And Rebecca.
Hi everyone, nice to see everybody here, and thanks Rachel for inviting me. My name is Rebecca Brown. I'm from Worcestershire Acute Hospitals Trust, so right in the middle of the country, heat wave with everyone else here, and I'm the Chief Digital Information Officer for our rural trust. Thank you.
Fantastic. Well, once again, thank you all for joining. And before we get going, we're just going to run a very quick poll question. And I think what happens as an audience member is once you choose your answer on the poll, it disappears off your screen. So we'll just keep it open for a minute while we're watching people vote. So what is the biggest barrier to digital healthcare access in your experience? And you only have one answer. Okay, I think it slowed down. So interestingly, the highest one there, well, there's 3 in the same area. So we're looking at lack of digital skills and knowledge, complex and poorly designed systems, and a fear or lack of confidence with technology. So that's quite interesting because, Ruhel, I'm going to come to you first. As a patient and patient advocate and community advocate, to tell us about your experience and your views on this.
Okay, well, thank you, Rachel, again. Hello, everyone. So as a patient and community advocate, working over 28 years with communities, are often excluded from healthcare access, especially in the digital space. And this is what we're talking about. And some of the stories of exclusion we're talking about, where I commonly hear regularly from patients who cannot manage digital appointments or apps. And this is a very common thing because a lot of it nowadays, appointments are gone through by the apps, and some miss vital reminders, others feel overwhelmed, anxious, and even ashamed. The elderly people, those without English as a first language, or people without internet devices, face the biggest barriers. So let's be clear, digital exclusion is a healthcare inequality. Systems are at times not designed for all. Many digital tools are made for patients, but not with them. And I think this is a discussion that we will have. Interfaces are focusing, language is technical, no help for those who struggle, that creates frustration and distrust within the system in the NHS. So really, what's missing? A genuine patient involvement from the start, that's what needed. We need to co-design tools with real users. So it needs to be meaningful. Patients bring lived experience, and that's forms of expertise. If we don't listen to them, then systems won't work in real life. As simple as that. So living with digital barriers equals feeling left behind. It's not about tech, it's about dignity, access, and confidence. People give up not because they don't care, it's because it's too hard. So what needs to happen? We need to build in inclusion from the start, as I mentioned. Offer non-digital choices, simplify systems, use clear language, add translation and accessibility features, support for people to build confidence. My final message to this is digital healthcare should reduce inequalities, not deepen them. People who need it most, we have a real opportunity, but we must listen. Thank you.
Ruhel, thank you so much, because I think your key message there is one that I absolutely agree with, which is build in inclusion, but build it in from the very, very start. And it's something that, you know, as an organization, we are very aware that it has potential, digital innovation has potential to transform healthcare, but only if it's designed with heart and putting patients at the very center and ensuring that no one gets left behind. So Tara, I'm going to come over to you because I think this is a conversation you and I have had in the past around design, designed with heart, designed with people.
Yeah. And I completely agree with everything that Ruhel just said as well. And as you know, Rachel, I've got this particular interest in models of care that are home-based and tech-enabled.
Yeah.
And it's interesting to see that on that poll, the thing around poorly designed systems is right at the top. It's really about changing the model of care. You know, if you've got a ropey model of care, the best tech in the world is not going to make it work for people. You've got to get the model right, and then tech that supports that, that's easy to use, has been done, proper user-based design. And I think that good tech at home can do a number of really important things. So the first is it can help cross that digital divide by providing devices and data to people who need it. It's thinking about all aspects of unintended consequences around cost that can leave some people out of services. They can provide a really different kind of service so that people interact with healthcare really differently, and it's very responsive. They can genuinely help people stay well for longer and flag issues much earlier so that there can be an appropriate response, and it's not always hospital that's the answer for that. And they can be designed and thought through with that inequalities lens at the moment, so that in fact it can help people who are in deprivation or face inequalities disproportionately. But that's when it's done well. And I do think that the NHS gets it most wrong for the people who use its services most. We mentioned that, didn't we, in that blog that we wrote, some more data this week from Ipsos saying that people with one or more long-term conditions have the most fragmented experience of healthcare. So we're sort of getting it wrong for our VIP customers, if you like. So if we could get it right for them, it's likely to help lots of other people. But talking about what kind of services get it right. So probably my favourite project of last year was a project called Living Well with COPD in Bristol. And it aimed to get the people who were most at risk of a hospital admission from their COPD, which is already a disease of deprivation to start with. And there was a feeling that it was going to be impossible to reach these people, you know, that we almost might as well all give up and go home, which I have to say I found only spurred me on in terms of my ambition to prove that that was not the case. Anyway, in the end, the biggest single cohort of people who were recruited to this digital-only programme supporting people at home were in IMD1, so the most deprived decile. Was the biggest cohort on this digital programme. I've not seen that before. And in fact, 40% of all the people helped were in IMD 1 to 3. This was twice the rate of the ICB average, so we had managed to get completely the right people. How did we go about doing that? We did think about things like language, which was on that poll to start with. So the website, which was written with a low reading age anyway, because let's be honest, people, it's about a reading age of about 9 across the country. So it's really simple, not over jargonized as we can be terribly want to do in the NHS. Animations, and available in the 5 most commonly spoken languages as well as English in that area. We A/B tested the text messaging, and we found that not mentioning technology so much and pushing the fact you were at home really helped as well. And devices were provided, data was covered. There were no worries that we were in some way adding to people's burden. Patients absolutely loved this service, and they reduced emergency admissions. They were able to get health coaching support for lots of those non-clinical reasons that can mean that people can get much sicker. So we can do it when we're thoughtful about it. And I just would like all tech programs to be thinking about those sorts of issues so that everybody is on board, and so you don't get that attitude from some people, but to be honest, it's just too difficult. It's not too difficult. We know the steps we need to take. We just need to do them with discipline, I think.
Lovely to hear that passion, Tara, about getting it right, because I think that very, very much builds on what Ruhel's just spoken about there, and to be thoughtful about it. I know as a patient association, we often speak to developers who I genuinely feel that they don't understand that they need to start with people. And I can get very, very frustrated. So I think that's part of the reason for doing the blog that we did together, but doing this and really hearing from Ruhel. So we've seen kind of that national, with a lovely example of living with COPD in Bristol. But I'm going to come over to Rebecca, because Rebecca, you're living and breathing this on the ground at the moment, aren't you? And I think we have some slides that hopefully
Yeah, thanks, Rachel. Yes, and I think like sort of 100 or so other acute community trusts, we are living and breathing this on a daily basis, and we hear you, Ruhel, and your concerns there. It's front and centre of what we're trying to do. So I'll tell you a little bit about Worcestershire. Some of you might know the area. We're a large acute hospital. We've got 3 sites. It's rural, but we've got a couple of big sort of cities. We've got Worcester in our area as well. We've got 8,000 staff, 300 fantastic volunteers, and around 800 inpatient beds. And you might wonder what a digital landscape looks like that supports that. And at the moment, it looks like around 150 different systems, some of them patient facing and some of them staff supporting systems. And as a digital team, my team's responsible for making sure that all of that runs smoothly. I've written in there a system within a system, because a lot of you will be aware of the complexities of the NHS mean that just our acute hospital and those big numbers that I've just told you about is just part of the picture if you're a patient in Worcester. So you might be accessing community care, that is through a different trust. You'll also be accessing your GPs, those are different organisations as well. And you might also be linking up care with local authorities as well, again, a different organisation. And I think it's really important to us from a digital perspective that patients don't have to retell their story again and again to different health professionals. And we see that, unfortunately, within systems, but also within our own hospital as well. It's not a great patient experience, and it's also not helpful for our staff as well. They need that information at their fingertips to be able to provide the best possible care to our patients. And patients should have that expectation that they don't have to retell their story. We've got, as most areas have now, a shared care record that allows our professionals to view patients' records across some of those trusts that I've just told you about, which is really fantastic that that's been enabled in lots of our areas. And it's particularly important where our patients have multiple or long-term conditions, because they are the ones that are going to have the most complex and lengthy health records, and also sort of lengthy prescriptions, etc., that may need to be looked at by different clinicians. It wouldn't be a true digital innovation discussion without us talking about a few of the more wicked issues from a provider perspective. I've talked about what we're aiming to do. Locally here in Worcester, we have frequent discussions around national versus local. You'll all be likely users of the NHS app. You may also be users of a local patient portal, which is probably bespoke to your particular area. Our aim in Worcestershire is to try and make sure that there's as fewer sort of apps and ways that you have to try and access electronic information as possible, because this can be really confusing, and you might be thinking, oh, my appointment is here, but actually it's on a different app. We would really love for the NHS app to be the single place where patients can go, so that they can access appointment information, their GP record, their acute record, and add information about themselves as well. At the moment, you're all probably aware that that's not currently the case. We've got some lovely innovations here in Worcester, and Ruhel, when you were just talking about non-digital access, I just wanted to use a particular example here. We've just gone live through our patient portal with enabling digital letters. So instead of sending a letter in through the Royal Mail to a patient, a digital letter will pop up on the portal, which is fantastic if you're digitally enabled and you want to be able to get it straight away. But what's also critically important, and from listening to our staff and patients, we made sure that there was that backstop of, if you don't access that letter, it's going out in the Royal Mail anyway. So I just thought how that's the kind of thing that we need to make sure that there's a backstop built into every system, so that if we are doing something digitally, we're also making sure that everyone can access it. And if they aren't able to access it digitally, that we give them equal opportunity to access it either on paper or by speaking to someone. I wanted to talk a bit about commercial considerations. Ruhel, again, you talked about the importance of patients being involved in the development of IT systems and digital systems. It's also really important that we involve staff, who are of course our patients as well. The majority of big IT products are through commercial providers. So as a digital team, it's really important that we work with those commercial providers to ensure that they're getting good feedback about functionality for patients and staff. It's really got to work for our patients and our staff, and not just be a technical product that we're buying, that we're procuring. So I just wanted to touch on that. And finally, I don't think a digital innovation discussion would be complete without talking about artificial intelligence. There's a lot of excitement and there's a lot of fear about this area at the moment. And I think in 5 to 10 years, healthcare is going to look completely different as we move through our AI journey. We don't want anyone to feel left behind on this. There's going to be a lot of change, and what we need to do is keep listening. So in Worcestershire, we've started an artificial intelligence ethics committee, and we've got our patient public forum members who are on the committee. We've made sure we've got a young person, patient and public forum member on the committee as well, to give us those views, so that we can really talk through with our local community and our own staff what AI looks like, and how that can be deployed safely so that it supports staff and supports our patients. I'll pause there, Rachel, and happy to sort of take questions and on anything that I've discussed there.
No, thank you so much. It's quite interesting listening to you there, Rebecca, because we had a webinar earlier this morning and we looked at breaking down barriers to equitable care. And one of the strong points that came out from everyone on the panel was that building of trust around data as well. So I think I'll come back to a question on trust and data and different communities. But first of all, and I think, Rebecca, you talked about like 150, I think it's like something like 150 systems running at ground level. How does that actually look? What does that actually look like for patients trying to navigate care?
So we really hope that from a patient perspective it's seamless, but we also know that it isn't. She won't mind me saying it. I've been visiting a friend on one of our wards every day for the last 2 weeks, and it's really interesting to sort of be doing the strategic digital bit, but also go down and sit with her and see how it's actually playing out from a patient perspective, sat in the bed and watching the person on their computer on wheel enter their information, look at their information. So from a patient perspective, it's not telling the story twice. That's how it should look. I know it doesn't always look like that. A shift changeover even can mean that that information perhaps isn't available to the next person if it hasn't been put on the electronic record. Rachel, electronic records are obviously a really important tool to make sure that the information is not just in one place, perhaps behind the nurse's station on a paper record, but is able to be accessed by whichever healthcare professional is dealing with that patient right there and then. Even if they've gone down to X-ray and then they come back to the ward, that record should be able to be accessed so that the best possible care can be given. I think that's probably a little bit more how it should look than how it does look at the moment.
No, and I've heard so often from patients. I had one patient one day saying to me, I have to bring a suitcase with me. I have a wheelie suitcase with all my health records and I have to share and repeat it time and time again. Ruhel, I'm going to come to you because patients are continually telling us that they're their own care coordinator. And Rebecca talked there about not telling the same story twice. How many times have I said this? I'm sure that you've heard this from patients in the work that you do, and I'm sure sometimes you feel like that again. How do digital barriers then compound the challenges of managing your own care or feeling that you have that power?
Okay, thank you, Rachel. Just want to say, colleague Rebecca made some great points, and I think there was some, it's about transparency, it's about being honest, and across the country there's inconsistency. When we talk about digital access to records and things like that, it's not just across the country. It could be from a borough to a borough. I live in Manchester, so the city hospitals, operate one way, and my local borough hospitals operate another way in terms of data sharing and things like that, as well as GPs. So Rebecca, I think she raised some really interesting points about transparency and about honesty and about some good practices as well and things like that, work that's going on around her way. So for me, the quote, I'm constantly having to be my own care coordinator, this is something I hear far too often. For people living with long-term health conditions, healthcare isn't just one-off appointment. It's ongoing, complex, and often overwhelming. Now add digital barriers to that, and things get even harder for some people. So digital barriers equal missed or delayed care for some. And if you can't access an app or a portal, you risk missing test results, not getting medication reminders, not knowing when or where your next appointment is. And I know Rebecca shared on that about, you know, the traditional route and things like that. Sometimes that's missed out. For someone with a chronic condition like diabetes, heart issues, or mental health needs, that's not just inconvenient, it's dangerous. So health inequalities make things worse, as many patients already face language barriers, poor housing, or low income. And then they're expected to manage complex digital system on top of that. So an example, a patient once told me that he had 3 different logins for 3 different services. And that could be common in some areas, as I mentioned, but no one had shown him how to use any of them. I think they assume, they just say, right, go onto the app, do this, do that. And it's an assumption that you should know what you're doing. No one actually teaches you or demonstrates to you. He missed multiple appointments and his condition got worse. He was blamed, but the system failed him. So I think it's very important. So the burden of self-management becomes a barrier itself. There's a lot of talk about empowering patients to manage their care, and that's important. But empowerment only works when people have the tools, support, and access that they need. And I think that's very important. Without that, we're just shifting responsibility without support and calling it empowerment. Is it really empowerment? Poorly integrated digital systems means duplicated effort. So patients tell me, I have to repeat my story again and again. And Rebecca touched on this. And you just mentioned it as well, interesting story, Rachel, about somebody has to take a briefcase. Wow. So digital tools should help coordinate care, but when they are fragmented, they do the opposite. People are left to chase referrals, track their own results, and make sense of medical language, often alone. Inclusion needs to be built in, not bolted on. We need to recognize that not everyone can or want to use digital tools. And so we have to respect that people's, value people's, whatever they are comfortable with. That's not resistance, that's reality. Inclusion means offering non-digital alternatives, language support, tech training where helpful, and most importantly, choice. Choice is very important. And for me, the final message that I want to leave with that is managing a long-term condition is already hard. For patients facing digital exclusion, it's like being asked to run a marathon with no map, no shoes, no one to ask for directions. If we want digital innovation to truly help people, we must start with those who face the greatest barriers. Only then we can create a system that works for everyone.
Well, thank you. I like that analogy of running a marathon, and I'm going to give you another patient story here now. And it was a patient with long-term conditions, and and because of the lack of interaction and the care navigation, the bits that everyone's spoken about, and Tara, the CABT service really starting with the people he needed. This patient on a webinar with me a few weeks ago said, you feel sort of worthless, like you've lost your dreams, like you're being left behind. Tara, we know that 35% of people with long-term conditions struggle to engage with their health. We will look at the positive ways forward from this, but when we talk about digital exclusion, Ruhel raised it, that this is building health inequalities. So how are we going to make sure that those designers and developers design with that accessibility in mind?
And that it's so interesting, that thing about engaging with your health, feeling confident about managing your condition. So a piece of work that was done last year and the year before was called Managing Heart Failure at Home. So 10 sites across the NHS using different technology providers, providing people with long-term conditions such as heart failure, you mentioned, Ruhel, cardiac conditions, with light touch remote monitoring support. So basically easy access to clinical advice. one of the kind of headline results of that was that, because sometimes there's a bit of a fear, isn't there, that maybe moving care closer to home means we are handing more care to overburdened GPs. But in fact, that what was seen in that big study was there's a 32% reduction in GP visits in the cohort, basically because they had ready access to advice at an earlier stage. They didn't need to see their GP and they didn't need to become an emergency admission. But there are a couple of other findings kind of under the headlines that I think are just as interesting. So one was, and this was only 3 months in, right? So really early days for people who've been living with this condition for a long time. They were asked to score how confident they were in managing their heart failure on their own. And there was, so the self-efficacy score it's called, there was a 4.84 improvement in the score of that question. In the next one about quality of life, about feeling that heart failure had less impact on my daily life, 10.2 improvement in score. So these are big changes in a short amount of time. And they speak directly to that point about engaging with my health, feeling confident with my health. And Ruhel, you're absolutely right. People need to be supported in that. They can't just be thrown things and, you know, ciao. There has to be a level of interaction, but on the whole, people do want to engage and they do want to spend less time in hospital and they want to spend time at home, but that conversation has to happen in the right way and they have to be provided with tools that are going to help them do that, not be a barrier to it. And some of the things that developers need to think about is not overloading passwords, not setting timeouts too short, you know, things that are just going to start becoming an irritation, which we know for cybersecurity reasons are important, but let's be frank about the risk of a device in somebody's home. To just Bluetooth, you know, so anybody with sort of sight or dexterity issues, sometimes you get older people don't like tech. That is absolute nonsense, as we know, but you can make it easier for people if vision is an issue or dexterity is an issue. You can have Bluetooth devices that require no tapping in at all. So there definitely is that thoughtfulness, but I was interested to see that done well, tech-supported services can actually improve people's own feeling of their self-efficacy and how they're managing their condition.
Absolutely. And I think what Ruhel and Rebecca were talking a little bit about, it's not going to be one size isn't going to fit all, and we need to go on a journey with people. So Atara, I'm going to ask you one more question now, but I think sometimes, like you've talked about co-creation and co-production with patients. What I often feel with a lot of system development, in a lot of the healthcare system, is that we don't try to reach those who are most excluded from kind of your traditional engagement measures, who may not want to be involved, may not understand tech, may not be able to access it, but they're the people we should start with. And I do have a concern that that's not where we're starting. So how would you suggest people do start there?
I think it's a mixed bag, though. I have the same concern because it's kind of easy, isn't it, to just think
Talk
about
to your neighbour.
Look, really easy, but there are notable exceptions of that. And I also think, so when Ruhel was talking about supporting and explaining, I really love this initiative that public libraries are now helping people use the NHS app. That's a great idea, you know, really helping sit down, almost being a kind of son and daughter to people who might not have one and helping them as a bit of a digital buddy. The Red Cross do some good work in this space. And also worth a look is that only a couple of months ago, the new government put out a digital inclusion action plan. We have had strategies before, but this is a little bit grittier and talks about practical things, including a scheme that's already started, where a number of government departments are giving their laptops and technology and phones that they're no longer using through the Digital Poverty Alliance to people who are going to use them for all sorts of applications. Could be education, but we know a lot of people will also use it as part of their health. So I think I do see some of that, Rachel, I must be honest, that happens, especially when people feel very busy and it's tricky. It's not difficult to get groups of people to give you views, right? There are lots of agencies who can help you access them if you can't yourself. There are wonderful charities and organisations such as your own. So it's not actually tricky, but people do think it is. So I think it's a perception.
No, I think, yeah, no,
as
I think
much
it's
as anything.
perception. It's a perception, but we do find it, and you're right, that some people do it really, really well. So obviously it's always going to be those pockets of good practice, but how do we get that to be across all the digital innovations? So Ruhel, how would you think that, you know, people developing tech, creating these digital solutions, how do you think they can really ensure patient voices, and especially those who are digitally excluded, are heard, are genuinely heard in the design
I think,
stage?
you know, I mean, that's a challenge itself. And, you know, statutory agencies or organizations who are working with this have to take that on board, you know, that challenge. Because, you know, it's not always about working with the ones that's engaging and let's work with them. Because don't forget, we work in it, you know, UK is a very diverse community. We've got emerging communities who are coming into the country, you know, from other countries. So they have to be accepted into the health systems. How do they learn the system? How do we engage with that community? And this is where part of my, you know, 28 years of experience working with different communities, understanding barriers and excluded communities and all those kind of things, really. So that is a challenge itself, has to be taken on from the start, about working with those communities, marginalized communities as well.
Brilliant, thank you. And Rebecca, so you and I've spoken a good bit about this, and we spent an evening together talking about different things, but from a trust perspective, how do you balance that push, and that right push towards digital innovation, with the need to maintain accessible services for all patients, building on what Ruhel's talking about?
Yeah, and I think it's very much at the moment this push analog to digital first. But what that doesn't mean is digital only. We've got to make sure that we've got these backstop measures, and that we're able to ensure that if people can't access, then they can access in a different way, be that paper, a phone call, or a home visit. You know, there's lots of different accessibility issues, and we need to be really mindful of them all. I think what's quite interesting here is around the digital literacy, which is, you know, how good are we at IT and digital? The poll at the start, it said 4% of our attendees here found it an issue accessing IT. And that was the lowest bit, and I think it's probably indicative of the fact that everyone's managed to join a Zoom webinar and is interested in digital innovation. I actually think that accessibility issue is much wider, because we're looking at a sort of subset of the population here. I'm continually concerned when I see my teenagers' school timetables that they still only have 1 to 2 hours of IT per week. It really worries me, and I don't think our schools' curriculums have moved quickly enough in terms of digital and technology. You know, our young people are learning this through their phones, through their iPads, etc. But there's something about learning the basics properly through schools, which I don't think is always happening. What we can do in the NHS is we can do guides, we can have tutorials, we can have champions from various different places. So some of our volunteers, they're digital champions able to help people use some of the technology that we've got, for example. And Tara, you've already mentioned the brilliant work that goes on in libraries, etc. It's also really important we work with our voluntary community sector, particularly for particular communities, to make sure that there's something accessible for everyone in terms of enhancing that digital literacy. And what we also need to make sure we do is monitor the take-up of the digital and IT solutions from a patient point of view. Who is being left behind and why? And where can we focus some of the resource to make sure that we can improve that uptake? We can't miss out on that monitoring bit either. But yeah, all in all, digital first, but not digital only.
Brilliant, thank you very much. And I think you've all talked about libraries. We know some really good examples of community hubs on the high road that do a lot about trying to enable digital access and increase digital literacy with different communities. But we do have some great groups out there that are doing that as well. And we have, you know, we've on the call today, we have some of our wonderful local health watchers and some of our local patient participation groups. How can we support those smaller groups? And Tara, I'll come to you with those kind of engagement mechanisms to make sure that they're hearing those digitally excluded groups.
Yes, thanks. So yeah, they're terrific groups to engage. Sometimes, and I've had this feedback from a patient participation group I was working with once, they don't feel that they're quite the right people to talk about it. So I remember we were doing some work on maternity, and the kind of average age of the people in the PPG, they were saying, I really was interested in this, but it's a while ago. So we were used instead the networks that are best able to give advice on and bring together actual pregnant women in the room and people who've had kids to participate. So I think it's a great place it's a great set of groups to use, but probably just not exclusively, because sometimes we want to do a really deep dive into the day-to-day issues of somebody who's like living with that condition as a bit of an expert.
Brilliant. And Ruhel, is there anything you want to add to that question?
Sorry, just repeat the question.
Just about how we can, so we talked about, you know, libraries, which is fantastic.
Oh, yes.
Areas without libraries, some of them have small community hubs. How do we get to, we had a conversation this morning about rural and coastal areas that are digital exclusion is an issue there as well. Yeah. So how do we engage kind of smaller local groups like your PPGs or your local health watch?
So I think, you know, working with the voluntary community sector and, you know, they're key, you know, sometimes there are lots of organizations stationed within the communities, work around health and needs within the community. And, you know, mentioning about the libraries now getting into this, supporting the communities. I think this is a great way, you know, we need to see more of these, you know, consistency, because I think libraries are a great hub. You know, everybody uses library. You know, you taught to use the library from the start of primary school. You know, you go there and children themselves will talk about it with their parents, you know, when they go home and things like that. So local community organizations and local libraries, other organization agencies who work around health, I think, you know, it's a good point to work with around supporting the communities, you know, in terms of their needs and support.
Brilliant. And there's a question in the Q&A, and I think it's a very good question, because I think I obviously haven't made this clear at the very beginning. Some people want more control of their health. Other people don't. So, and that's okay too. It's about how confident we feel, and there is that patient power, but that's another story. So, is there anything anyone wants to say about that? Because I think it is back to that one size doesn't fit all. And if we can get digital to work to people who really want it, and those people who are helping to become more powerful, that then frees up time for people to have access in different ways as well, doesn't it?
Yeah, it does. And I think it is about personalization, isn't it? It's one size absolutely doesn't fit all. And I think in the past, the NHS has been very one size fits all, and hopefully it's starting to move to a more personalized model. And that will include your digital preferences within that.
No, brilliant. Because I think that on the session earlier, breaking down barriers to equitable care, Charles from the Caribbean and African Network, the chief executive there, was saying there is a lot of historical context that we need to understand as to why people may be more nervous about digital, maybe more nervous about data. Rebecca, is that something that you've been thinking about within your role?
Yes, I'd agree, and I completely agree, Tara, about the personalised care and what's best for patients. I think where we're operating in the financial constraints and the resource constraints that we've got, what we would like to do is empower everyone who wants to be able to use digital, so that wanting to is not the barrier, so that we provide the personalised services face-to-face or on paper, etc., to those who absolutely need it, but ensure that everybody else that can do it digitally, because ultimately, although we absolutely want to provide that personalised care experience, we are operating within a system that has significant constraints in it. But it's about doing that in a really sensitive and targeted way to ensure that patients do feel comfortable with that. And if it's not the right thing for them to be using an IT or tech resource, and for many, many different reasons it might not be the case, then we shouldn't require them to do that.
It'd be very interesting. We're 2 days before the launch of a 10-year health plan, which we're seeing being launched every day this week. But be really interesting to see, because I think there's some conversations in the chat about the role of the PCN, how can they help rolling it out. And it'll be really good to see how that shift around analog to digital is going to be enabled, and this whole section on patient power, which I think is really important. So I'm going to run another poll now. And this poll question, I'm giving Holly a chance to get it to come up, is how confident are you that current digital health innovations adequately consider the needs of digitally excluded patients? Okay, so we're going to give you a few seconds again. Okay, I think we've got a clear winner here. Nice to see that somebody is very confident, which is fantastic. But I'm going to come to you, Tara, because they're not very confident, and they're not confident at all at the moment. Is definitely out in the lead there. And we'll do something with these poll questions after this event as well. How are we going to get better at doing it, Tara? Because there are, and you're absolutely right, there are pockets of brilliant practice out there, and we all know about them. But inclusion feels like very much an afterthought, nearly 50%, and digital inclusion is widely overlooked at 25%. Implementation varies at 22%. How are we going to do it?
So it's interesting, isn't it? Because I think the digital products that we all know that are kind of household names in health have done loads and loads of work with patients. Loads, right? They wouldn't have got to the point they are without thinking about that. But I think what Ruhel mentioned is really key to this. The way they're sort of strung together at the moment makes it very clunky, right? So yes, you can get in things through the NHS app, but then you've got a separate login for your health record. So individually, those products spend lots and lots of time with patients. It's that design of the system ain't yet there yet at all. And I wouldn't want to claim that it was. It's really tricky for people who do this as a day job. Never mind, some of my relatives. So it's not, I wouldn't want to claim victory, but I don't think it's got to that point out of a lack of thinking about it. I have seen lots of products, but thank God they didn't really make it, where they really hadn't thought, maybe they had a clinician who had a great idea, or they had a tech bro who but they hadn't really sat down, but they just don't succeed, right? Because it's quite hard to succeed as a health tech product. So I do think people are giving that thought. And I'd also want to say, it's not something you do once, right? You don't just do it at the beginning when you develop the product. You have to do it all the time. Every time there's an iteration, every time the care process changes a little bit, you've got to see, what do people instinctively do at this point? And the ones that succeed do have clear interfaces that are super simple. They resist the urge for bells and whistles. They don't try and make it look amazing. They think about accessibility from a contrast point of view. But I do think the way it's strung together at the moment, which I think is a transitional thing, and we will come to the other side and it will be slicker, but it's not like, the ease at which we use lots of products privately. The NHS has not got there yet, but I think it will. What do you think about it?
Yeah, Rachel, would you mind if I just came
Yeah,
in
no,
with
please
this?
do, please
I've
do.
just been thinking about a subset of our patient group, and that's our staff, because all our staff are patients as well. And I was just thinking about when we went live with our electronic patient record. So that's the record that holds most of the information about the patients in our hospital. Now, the anxiety levels in our staff as you go live with a product like this are high, really high. People are really worried. They don't feel that they've had enough training. They're worried about using it and they want to do it right for their patients. As you sort of go around floor walking on the morning, we always do it in orange t-shirts on go live days so that people can find us and the staff go, oh, can you come over and help me? And the morning that we went live, I remember walking around, helping people. And when I came back after lunchtime, I saw some of those staff who we'd helped in the morning showing new members of staff who'd just come on shift how to do it. They'd been given that confidence through the training and also through that hands-on, at the elbow support. And I wonder if there's a way that we can replicate that for patients out in the community, where that anxiety and the worry about doing it wrong and not being able to do it translates into them becoming advocates for a better way for them to use the digital systems.
Yeah, no, I absolutely. And I think that's a really good point. I think frontline staff as well can also, there's a lot more trust. And if I think about data and historical and issues around trust within the healthcare system, I think sometimes frontline staff hold much more trust with patients than maybe system holds with patients. So working like that, Ruhel, what do you think of what you've just heard?
Yeah, I think it's about honest dialogue. It's about honest dialogue, and people do want to help to improve systems. So, for example, one of the things in terms of you talk about VCS organizations, I think very important is to have some sort of community networks, where people directly from the community are involved about voicing their opinion about making changes. We do it for every other things. So this is just as important about making, digital changes to come ahead, really.
No, absolutely. And I think, and one of the things that came up in the webinar before this as well was talking about, some of the really good successes with the vaccination program during the pandemic was the way we worked with local communities to understand the barriers. And it was local communities who worked with local communities and then managed to have those conversations. So I suppose, Tara, how do we do that? So, if you think of the more traditional methods of engagement, surveys, focus groups, things that the patient association do as well, but we really try quite often then to really get into local communities through different leaders within the community. How do you think tech could do that then, to kind of build on what Rebecca and Ruhel have been saying, where you could have, communities supporting each other to build, to help us understand the barriers more, but also then to build confidence?
I think it's got to be multifaceted, Rachel. There's no one size fits all for how people would want to access that support and training. I've just seen in the chat, what about people that live a distance from libraries? You're absolutely right. And maybe a poster on the notice board at the local community hall is the way to go for that kind of community. But we've got to spread ourselves really wide in terms of how we make this accessible. I talked a little bit about tutorials and people being able to find out how to use an app via a tutorial. That's only any good if you actually already have access to the internet and to that tutorial. So different voluntary and community sector organisations, local authority and some of their staff, for example, family support workers, people who will see areas of society that perhaps aren't talking to other professionals. When you come into a hospital and you're met by a volunteer, are they able to say, do you need any help with the NHS app? Or come and sit here in our little tech bar and we can just show you how to upload it onto your phone. Whatever it is, it needs to be multifaceted so that it meets everybody's needs.
Brilliant. Tara, do you want to come in on that?
I just agree with that. And I think picking up the comment about the NHS app being particularly helpful in one of the Q&A. It's now got more, but being a bit of a secret, it's got more subscribers than Netflix using the NHS app. I mean, it's really, really massive. The thing most people are using it for is repeat prescriptions, but a lot of people are looking at their health record and using it for appointments as well. And I imagine we're going to hear more on Thursday about it being extended. So that is saving people a lot of time. And also just the point about rurality as well. You know, we avoiding trips to hospital has got a big benefit for all sorts of people, but particularly when that's a massive journey with a big parking or bus fare related to it. So there's a kind of social justice element to trying to harness technology to put care in the place that is best going to serve that person as well.
Yeah. And rightly, I think that the social and structural determinants felt that we need to address in that. So it's a lot of conversations in the chat around rural areas and lack of mobile coverage. And I know that that's something that I think the plan will, and the digital action plan that you mentioned, Tara, did bring up how we spread into rural and community areas that may not have good digital access, and the same areas probably don't have the library that you can go and do your NHS app on a computer, but that's something I think coming out. So we have all of 3 minutes left, and we started this looking at, you know, the great work that's happening in digital, but what we wanted to talk about was making digital innovation work for everyone, or for everyone who wants to be involved in it. What is the one thing we need to do to make sure that we achieve that webinar title? So, Ruhel, what's the one thing that we have to do to make digital innovation work for everyone?
I think it's a buying thing. You know, people have to have a choice, first of all, and secondly, it's about building confidence amongst people. You know, you talked about the app, the examples of the app, the things that you can capture within the app, the NHS app. It is amazing, but how many people know about it, the benefits about it? So really, we've got to sell the benefits and build the confidence and the trust, and that's the key thing. Really, you know, we need to do that.
Brilliant, thank you, Ruhel. Rebecca,
can I cheat and have two?
Yeah, yeah.
I'll be quick.
Have to. No, you
so
can
the NHS app, I think we should use that for everyone. It will be simpler. But the other one, and this is a bit more controversial, is I think we need to harness artificial intelligence in a safe way, which our patients and our staff can trust. It's the future, it's coming, and it's sooner than we think, and we need to do it in a way that our patients are happy with.
Yeah, with patients and staff, and make sure that they're involved from the very beginning, but all the way through, like Tara said. Tara, you get two now as well, because...
It's all right, I've only got one. Go on.
Oh, okay, Ruhel got three, Rebecca's got two, and you've got one.
So I think that done intelligently, tech-enabled services that enable people to manage their care at home and not in hospital can also help to close that digital divide. So let's make that the norm across the NHS. They're doing it in Denmark. We could do it better here. That's what I'd like us to do. Please. Okay,
we can do better than Denmark. That's our closing statement. So I think what I'm hearing from you all, we know, and I don't think anyone is on this call has said, we don't think digital innovation or AI are not good things. They are good things, but I think the message is loud and clear that we need to bring patients and frontline staff with us on this journey, because that's really, really important. Thank you all for attending. I have Sir Jim Mackey joining me tomorrow afternoon, and I will be asking him some of the themes that have come out of today's question. We then have another session on Thursday around patient partnership, which get the theme, it's Patient Partnership Week, and we've talked about it today, about how we might make sure that we do all of these things in partnership. And then I think, Ruhel, especially some of the stuff that you've been saying, and I think we highlighted here that communication is so important in this, communication and bringing people. So we've got another session on Friday morning, which will be looking at how we really truly work with patients to build those healthcare campaigns and communication campaigns about what's happening in the system. here is our support our patients. So our work will continue. I think Thursday is going to be really exciting, having a 10-year health plan. What I'd be really interested now is actually how do we work in partnership with patients so that they absolutely are involved as true partners in the implementation as we look at the shifts that we need to make, which are good shifts. So if we do that, the next slide will talk to you about our free membership. But we'll also, our helpline is there. If any of the issues that we've discussed today that you'd like more guidance or information, you can always ring our National Free Phone helpline, because they can help either answer your query or put you in the right direction. Once again, thank you so much to the panel and to you on a very hot day across England, in the UK. Thank you for joining our webinar, and I hope to see you at one over the next couple of days as well. Many thanks, everybody.